This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Welcome to this episode of the 1 Million Lives podcast. Certain cardiac arrest remains one of the leading causes of death among adults worldwide. While public awareness of CPR is on the rise and access to defibrillators is improving, survival rates for cardiac arrest victims remain relatively low. Research indicates that early CPR and the prompt use of a defibrillator are critical factors in enhancing survival chances. Today we're heading to Stockholm, Sweden to explore a project known as the Heartrunner. This system mobilized community first responders to the site of a cardiac arrest, potentially saving lives. Our guest today is David Fredman, fittingly titled The Heart of Operations at Heartrunner Sweden AB. So David, first, welcome to the 1 Million Lives podcast. And second, what is Heartrunner? Please tell us more about this project.
In this case, I'd say Heartrunner is the company that operates a platform for alerting community first responders in cardiac arrest. A Heartrunner could also be the individual that engaged in this and allows to be alerted and to respond to a call for help.
Can you tell us a little about how this initiative started some years ago?
Sure. I have a background as a nurse in cardiology and also a PhD from Karolinska Institutet. And the idea, the concept was, it's born from dire need. I was involved in a research group with focus on cardiac arrest. And one of the professors had sort of an epiphany on a bus that was not departing from the bus stop for no obvious reason. And when he got to the ER and has changed and started his workday, someone told him that, there was a cardiac arrest in that bus stop. Don't you live just nearby it? And that sparked the thought, how come that I'm with all my knowledge and all my training and all my skills, I have no idea what's happening 3 meters away? He could potentially have done something. He could maybe have changed the outcome. But this sparked the idea. We know so much, and yet we know so little.
And then he took the initiative to start it?
Yeah, and this was before smartphones. Lots of thinking and trying to understand, and as always, the timing. Timing is always crucial. But this was, at least in Sweden, it was starting with like predating smartphones, using internet for getting some kind of push message when you're close to a pizza restaurant, perhaps, and might get a 5% off. Or there was a service supported by Telia, the major phone operator, that you could find your friends just wherever they were. This was, much more than find your iPhone or find my Android. And could that be used for something? Notifying someone that knows to do CPR. And they spent a tremendous amount of time, and so many great ideas had to go down the bin. But back in 2006, 2007, the ideation was good enough to be written down as a research project to alert volunteers in cardiac arrest and ask them to change location and perform CPR. That's as simple as that. We need more hands on the chest of cardiac arrest victims.
Can you tell us some of the challenges that your company met? You talked about some. There were no smartphones.
This was not a company at that time. It was a research group. So there was no company involvement at all for the first 10 years, more than that. It's always interesting to be the first to think about something. We were seen as crazy people, no doubt about it. I think lots of people were quite sure that this will never succeed. no one wants to help. Swedes are seen as quite reluctant to communicate with a neighbor. We don't make eye contact in the elevators. We're kind of introverts. In some might see it that way, but I think that the major thing that people from the medical community were seeing as how dare you even involve volunteers? People, they've trained CPR, but they are not medical professionals. They're not nurses or doctors. They are not EMS. They're not employed. And to put this in the context, in Sweden, training in cardiopulmonary resuscitation, it's a big thing. Over 280,000 training CPR trainings are held every year.
And on a population of 10 million.
In a population of 10 million, yes. So lots of people know what to do. And maybe this is the strength in numbers. To engage this unused potential in society became a bit of an obsession, actually. If this was another type of podcast, what is the key to success? I would say persistence. If the idea is good enough to pursue, you will win. Sometimes I get asked, why do we do this? I think I learned first aid and CPR in that case when I was a scout at 10 years old, 1985. And then I trained as a staff nurse, and I went into the army as a medic. And then I finally took my exam as a nurse in 2001. And then I started training CPR annually, and also held the position of being like a CPR instructor for my entire hospital. Never once did I do CPR when I was not in clinic. So I've known CPR for so long and never got to use it in society until I was alerted through this system that I has been involved in building. And this is, I think, the driving force why so many people know what to do and they never get the chance to use it.
Did you meet any challenges, or did you encounter any challenges when it comes to the law of the country?
Not in that exact sense. We have quite good protection, like for first responders or for first aid. If you're doing this for the good of the person, then you're quite well protected. But for the first research phase, we had ethical approval to only alert to cardiac arrest in public locations. So that's, well, in this context, 80% of all the cardiac arrests, they occur in private homes. So we were only looking at like 20-25% of the potential cases. And it took about 3 months, and then we were approached by some higher-ups from the dispatch organization saying, this is a problem. My dispatcher cannot 100% identify the differentiation between private location or public location. So could we maybe make the change to this? And also, they feel bad when they do not activate your system in 80% of the cases. So we made an amendment to the ethical board, and it was approved. So no legal issues, but practical issues.
This research organization merged into a company. And so how is this organized in Sweden today?
Just quickly on the transition from it. When this research was ongoing, we were approached by several regions in Sweden. There are 21 regions in Sweden, and we ran this research in one, starting up in one of them, and then doubling it. So 2 were involved. And we were approached by several saying, this is a great idea. We'd like to use this. And since we were researchers, we said, would you like to join our research? And they said, no, thanks. We would like to use this. And we totally misunderstood everything. And we were like, looking down the wrong hole. When the research phase was finished and everything was published, we were approached by the innovations company tied to the university. All Swedish universities have innovation companies tied to them to assist researchers and teachers in bringing ideas and inventions into business opportunities. So we were actually approached by Karolinska Institutet's innovations company saying, you got something here. We would like to help you with a business model to take this for public benefit. So that's what happened. So now it's a company. We are nearing 10 employees. We have external developer teams that are dedicated to the back end and front end. And most of my colleagues have not a medical background. I am a nurse, and my colleague Jessica is a nurse as well. And then it's just motivated people. But I think it's really important, and one of the things that I've been fighting a bit for over the years, to keep an eye on the research and be close to the heritage of science. A system like this needs to be evaluated, and I think it's great to be evaluated by independent researchers. So if I just, quite shortly, if you have a decent research proposal and your ethics are in check, then we will share data with you. Because this should be analyzed so that the region using the system, they should be in control of the data to analyze the outcome. I think that's really a key to success in our case.
I understand you have already expanded into Denmark.
In Denmark, since 2020, all 5 regions are using our system to alert volunteer responders under the umbrella of the Danish Safety Foundation that have done a tremendous job to make this something that Danish society expects volunteers to show up on cardiac arrest, which is, I think it's so impressive. But yeah, expansion, of course. Our idea is so good, so it's worth expanding. Looking at the Nordic countries, looking to Europe, but also, again, the heritage of research to support scientific endeavors in wherever they might be. Our system is built for research, and it works well. Yeah, we'd love to assist in saving more lives in cardiac arrest, for sure.
Of course, there are other similar organizations in some countries, but most countries do not have something like this. So I'm sure there is an opening if you look at the big things, in the big scheme of things.
You're listening to 1 Million Lives, a Laerdal podcast.
Let's go back to the community first responder, or the Heartrunner in your case. If I want to become a Heartrunner, how do I go about to become one?
Now I'm talking about the Swedish setting, and which is the same in Denmark. When you take a CPR course, when you learn cardiopulmonary resuscitation and to save a life, you don't get a certificate. There is no registry for knowing who took the courses and not. So in Sweden, if you're over the age of 18 and you know how to do cardiopulmonary resuscitation, you're welcome to join. Download the app and you're free to go. In another country with different laws and different setups of the training, how the infrastructure is, there will be scanning of a certificate, or maybe you need to be associated with some kind of volunteer organization, or maybe employed by the healthcare regions, whatever. But this is the way it's set up. It's very easy entry. Cardiopulmonary resuscitation it cannot harm the person that you give it to. It cannot make things worse. They are dead, and you can only make it better, or they stay dead. So this is I think that the safety measures should change when this is introduced into another country. And if we look at the European, the similar systems, they have different setups where might be required training at this specified site and will be overseen by some kind of entity. And I think that it's very important to understand that I represent the platform, and whatever is being entered into that should be decided by whomever is running this.
And one of those who did the CPR course, I assume, and who decided she wanted to join as a community first responder was Anna Lindqvist. Hello to you.
Hi, Björn. Nice to be with you.
Can you tell us a little how you ended up being a community first responder with Heartrunner.
Well, I first heard about this, I guess, on social media. I've read about this first responder thing because Stockholm was a little bit some years before us down where I live. And then when the region down here offered this opportunity, I immediately said that I want to join this. If I can help someone, I will do that.
What is your main motivation for being part of this organization?
Well, my main motivation is if I can help someone continue his life and live his life or her life with their families, to me, that is fantastic. And Sweden is a really, really big and long country. And if you live in a city, it's quite easy to have an ambulance nearby. But if you're out in the countryside, it's more probable that someone can come and help you before an ambulance or a first rescue service can come.
How long have you been doing this now?
I don't know. Maybe it has been down in this region for 6 or 7 years or something, I would say.
It started in 2019, I think.
Yeah, could be.
What part of what region of Sweden do you live in?
I'm in the southeastern part. I live in a city called Karlshamn in the southeastern part.
All right.
So I think I was actually one of the first that responded to be a volunteer.
I see.
Mm.
And have you had any personal experience as a community first responder that you want to share with us?
Yeah, I've been to a few places where there was a cardiac arrest, and one of my very first was to an elderly man. I was there a minute or two before the ambulance arrived. So I just had time I found the apartment where this man was lying, and I started helping him, and then the ambulance people arrived, and I could instead talk to his wife and try to explain who I was and what was happening. So in a way, I could also help the ambulance people, but with other things.
I have personally a background from the emergency dispatch center here in Norway. And sometimes my personal experience is that to have someone who is not directly emotionally involved in the situation, to get clear and concise feedback of what is happening, it can be very beneficial for the professional teams on their way. So I can very, very well understand that. I understand you work in an office. Can you take us through the motions? What happens when the alarm goes off? How are you alarmed, for instance?
Well, I have almost my phone with me. It's, everyone is carrying their phone nowadays. And all of a sudden you just hear a terrible alarm and your heart starts running wild because it's so loud and you get an adrenaline kick. And then you realize that it's this alarm that you have a call. And then I always look on my phone and it says there is a cardiac arrest, and you get the address and how far away from the place I am. Sometimes it's only like 200-300 meters, and that's very, very close. Sometimes it's longer, of course.
Arrive at your destination. Arrived.
And you grab your coat and run?
Exactly. I remember the very first time I changed my shoes. I took my coat on. I looked for my car keys, and you're very stressed because this alarm triggers you. So I got dressed, and then I started walking. I wasn't sure if I should run. We're called Heartrunner, but how fast can you run? And if I run too fast, how tired will I be when I get there? So I sort of walked over there. But now when I get alarms, I don't take my coat. I take my car keys if it's longer than 500 meters, and then I actually run. Because you do save a minute or two if you don't look for your jacket and if you don't change shoes. And if a person has a cardiac arrest, that is a long time.
So now you are wearing sensible shoes at work, so you're ready to run?
All the time, ready to go.
So
actually, I have been running in high heels, so it works too.
Well, I can assure you I have never tried that. So I can just imagine how difficult it can be.
Yeah.
If someone wants to start something similar somewhere else in the world, What advice would you like to give them?
It's very important. And I think if you're thinking about this, then you already are halfway there. Because if this is not seen as a problem in your community, and if your dispatch center are not differentiating a stroke from a cardiac arrest, or if you maybe your resources are so scarce that you do not respond to these type of cases, then it's not going to work. So I would say to have three things are very good to have. You need to have an infrastructure of knowledge that someone is training someone in cardiopulmonary resuscitation, so that this is spread at least enough in your community. So you have someone to respond. Someone needs to know what to do. And then it has shown over the years, it's very, very good if you can have a good collaboration with the healthcare officials, with the ambulance organization, with the dispatch organization, so that they don't feel offended when someone else steps in as a resource for the first minutes. We've actually had this discussion. It's kind of interesting. It's a bit funny. The first time we introduced to increase survival in cardiac arrest in Stockholm, we first of all introduced and trained the firefighters and gave them defibrillators and dispatched them in parallel with the ambulance. And then the ambulance official said, we don't really like this. We think we're quite good at this. This is where we do our part. Like, well, the survival is very, very low. So maybe please try this. And it doubled the survival. And then we introduced the volunteer responders, so the community first responders. And then the fire chief said, well, I think we're quite good at this. This is actually what we do now. So do we need more people? And to smoothen this out, make sure that you have a great community of responders. And then it's very, very important to have your data in check so that you can analyze the outcome. If you don't know if there is a problem, it's going to be very, very hard to argue that you improved anything. So have some kind of registry for cardiac arrest and make sure that you can analyze before and after at least. I think that those are the three key components. Someone who is trained and knows what to do, and that you collaborate with the other responders, the ambulance in its primary, and that you actually can analyze the outcome.
It can be quite hard for people, especially the first few times when community first responders or anyone respond to an emergency situation. Do Heartrunner have a system where they are following up volunteers after an event to check that they are okay and if they want to talk through what happened and things like that?
The system is so well built into the healthcare regions that we have sort of the interaction is between us as platform provider and then the healthcare organization. We send out a survey after each alert for the responders to, again, this follow-up thing. You can say, yes, I took the alarm, I arrived there, I performed CPR, I did not use the AD, etc. And the final question in this questionnaire is also the contact details to your region. There you can reach out, it's an email, and in some instances also a phone number, so you can get in contact with them. We have just soon to embark on a collaboration with an insurance company where we will offer maybe more intense follow-up, not really because we see this as a problem, but we think this is beneficial for the volunteers. It's good. This is how we should do it. It's not because there is a massive problem. There has been several research initiatives, both in Sweden and in Denmark, and also from the Netherlands, looking at the well-being of the responders. And yes, there are some PTSD, and there is, of course, this is a stressful situation, just as you say, Björn. But in larger numbers, we're looking at small percentages. A Swedish publication actually said that the responders that had been exposed to cardiac arrest and doing CPR, they felt better, more motivated, more happy, more alive in this sense than people that had not been alerted yet. So this brings up something, but yeah, we are going to strengthen the net around the responders in Sweden to take better care.
I can just fill in that when you come to, very often you are more than one first responder that is coming. So very often we are talking afterwards or during or like taking care of each other also. So it's part of the package, I think. We do this because we care for real.
Yeah. And I think it's like to fill in on this, that in Denmark, the Safety Foundation, they have a saying for when they sort of aim this towards the Danish society. If you know CPR, if you're over 18, and if you are robust enough to respond, you should know. Well, you know yourself. You're the best. But if you sort of, I don't know, I'm easily stressed, or I cannot run that fast, or I get scared, or then it's not for you. This is not for everyone. But if you are robust enough, I think give it a try. You can always opt out. My colleague Jessica, she picks up on things that I say, and when we are introducing this, when I'm holding lectures, or we have like workshops for the CPR instructor group, sometimes there's a spark. Okay, now we're going to stop. People don't need to die from cardiac arrest. This is going to be great. I think it's very important to turn that expectation down a bit. We cannot save everyone dying from cardiac arrest, but it's great to give more people a decent chance of surviving. You shouldn't die from bad luck. There are so many people that are willing to help you, and there are so many people trained in helping you. And this, I think, is one of the driving forces.
Well, thank you, both of you, for your time. I just want to say that this has been a very interesting conversation. And I'd like to say good luck in the future, Anna, during your future response in sensible shoes and without a coat. And Dave, congratulations with how far you have come so far. And I hope that this will continue to prosper, and that more neighbor countries like Norway, for instance, get to try this in the near future. Thank you very much, both of you.
You're welcome. Thank you.
And that wraps up our exploration of the Heartrunners in Sweden and Denmark, a compelling example of how a great idea can transform into reality. If you'd like to learn more about Heartrunner, visit their website at heartrunner.com. Thank you for joining us for this episode of the 1 Million Life podcast. I'm Björn Egeland, and I was your host today. Until next time, take care.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.